Hello and welcome to Medical Monday right here on E-Radio. It's Jan with you, and we're joined by ophthalmologist Dr. Dylan Joseph. Today, as we promised, we'll be talking about medical aids, and Dr. Dylan Joseph will talk to us about medical aids and all you need to know, because it is quite a hot topic. Am I right, Dr. Dylan Joseph?
Yes. Good morning, Jan. Yeah, it's a massive topic and a bit of a bone of contention here in South Africa. There's a lot of misunderstanding, misconceptions amongst the public, and misguidance as well, I think, on behalf of the medical aids front. So it's important to try and understand the intricacies of it, and what your plan is and what your scheme of benefits are. So yeah, lots to talk about.
Right, so let's go way back to some of our first questions. Medical aids, by law, they need to contribute towards funding a procedure, unless, of course, there's a designated service provider. So how will I know if my medical aid will pay for my surgery? Specifically, let's talk about, let's say, cataract surgery.
Yeah, very, very broad question, but basically, medical aids work on different plans, and within those plans they've got different schemes of benefits. A lot of the plans that are basic will be, for example, a hospital plan. So even for what we call a PMB, or prescribed minimum benefit surgery, they will only pay at their scheme rate, their designated scheme rate, for that surgical procedure when you are in hospital. For all your consultations that are key to the diagnosis of, for example, a cataract, they don't pay for that, because those services are basically received by the patient outside of the hospital environment. So doctors' consulting rooms are usually not in the hospital. Although a cataract is a prescribed minimum benefit, or a PMB, you're 100% right. Medical aids by law are obliged to pay in full for the doctor's surgical fee. Now, actually, that should extend to the consultation portion as well, because the prescribed minimum benefit, when you're diagnosing the cataract in your consulting room, it's a PMB condition, so the medical aid is actually, you're right, legally obliged to pay for it. And in the surgery, they're legally obliged to pay for it at the surgeon's rates, not 100% in inverted commas of what the scheme rate is. Now, the loophole for the medical aids there is if they have what's called a DSP, or a designated service provider, within a 50-kilometer radius of the hospital or the day clinic where the surgery is going to take place. Now, there's even more perverse incentive involved in that, because some medical aids will default the patients to certain clinics. They don't know what technology is going to be used there. They don't know what the quality of the doctors are there, but they will default it to those clinics because the clinics have a contract with the medical aid. But getting back to the DSP arrangement, essentially a DSP, designated service provider, is a doctor, which is such a terrible name for a doctor, but it's a doctor who then contracts themselves to the medical aid and agrees to charge a contracted fee to that patient. So it's usually above what the baseline rate is for the medical aid, 100%. So it can be 117%, 126%, it can be 217%. And those doctors are then not allowed to charge any co-payments if they have signed these contracts with the medical aids. Where it then puts the pressure on the private doctor is, say 90 out of 100 doctors in an area are signed up onto a medical aid, but the 10 other doctors are not. What these medical aids are going to say, oh, sorry, hang on, you've got a DSP within a 50K radius of you. I understand that you want to see Dr. X because that's who you've been referred to, and he's got good qualifications and his surgical outcomes are fantastic. But no, you know what? You have to go and see Dr. Y if you want us to pay, because he's within a 50-kilometer radius, which in itself is perverse incentive. So there's unfortunately, when it comes to medical aid contracts, there's no emphasis on quality outcomes. And so that's where it all should be. If you're looking at, for example, global fees, and that's where medical aids and contracts and bundles are moving towards, is a global fee for service. So the day clinic or the surgeon gets one entire fee for the anaesthetist, the surgeon, the consumables, the day clinic time, the theatre time, etc. And they then divided up amongst those different basically stakeholders. The problem comes in where there is no quality outcomes. So if you were doing it in centres or units where the outcomes were standardized, they were monitored, they were followed up, you'd get a really good idea of the entire care required and therefore financial input required from the medical aid from A to Z with the best possible outcome. Where now is where no emphasis is put on that, your outcomes may be suboptimal, so you end up going back to the doctor for another repeat procedure, but it's okay because that doctor's charging the medical aid rate. Or at the end of the day, and worst case scenario, you're dealing with a cancer, which is a PMB2, and now it's been operated 2 or 3 times and has a less than optimal outcome, and now has to go to a specialist who is not contracted to that medical aid, and then the patient has to pay out of pocket. And in some cases, then it may be too far down the line. So there's a lot of detail around that one needs to scrutinize in terms of the ethical code and conduct. But those are the unfortunate things of medical aids in regulating the industry.
Very interesting, Dr. Joseph. The next question is, what do I do if I'm a private paying patient?
Private paying patients who basically don't have any medical aids, my strong advice is that you have a savings account that you put money away into every month, and that's your own personal savings account. It's okay for your day-to-day consultations with your GPs and your specialists, but where it's really going to hit you hard is when you're admitted to hospital, because there the hospital costs are far higher than what your specialist costs would be. The hospitals charge per minute. The day clinics versus the overnight clinics have fee structures which are quite different. And then if you end up in ICU, that could end up costing you hundreds of thousands to millions of rand, depending on what's wrong with you. And that's when you really do need some form of medical aid cover. But you've got to be prepared then to pay at the surgeon's or the GP's rates if you do not have a medical aid. And the problem is not being on a medical aid. If you have, the older you get, the more pre-existing conditions you're going to develop. Hypertension, high blood pressure, cataract. And when you then decide, oh my goodness, I need to join a medical aid, they're going to exclude these benefits for a year or for 2 years. So they won't cover you. Medical aids will not cover you for a certain period of time, and until they decide, okay, you've seen out this first part of the contract, we'll now cover those as benefits under your plan. But then it may be too late, or a patient's cataracts may be so severe they can't drive anymore. So you see, it's a catch-22. It's nice not to depend on the medical aid, but at the same time, they actually are really helpful when you do need them.
Yeah, so I guess it's also hard for you to say what the co-payment will be. It obviously depends on the situation and the condition.
Well, that's an interesting question. It depends on what the doctor charges. Is the doctor contracted? Because if the doctor is contracted to a medical aid, there will be no co-payment due. But I need to then discuss basically why that's those fees that the medical aids reimburse at contracted rates or at baseline 100% rates are actually unethical and actually were deemed illegal, and they were thrown out of a court of law by Judge Eberson in 2009. So basically, and this gets into quite an in-depth discussion, but the medical aids reimburse doctors at what's called an RVU, or a Rand Value Unit. And this Rand Value Unit was based on a reference price list which was developed in the 1970s and has not been changed since then. With inflation, nothing has changed. So basically, the medical aids are billing the surgeons per minute, and they've basically said for a surgical specialist with 14 years of training, they'll bill you 11 Rand and 5 cents per minute for surgery, and at 19 Rand and 74 cents per minute for consultations. So what is even more perverse there, apart from that fee, because if you look at what they pay their principal officers in the top 6 medical aids, is 3 times that. Okay, so they value their service to the medical aid 3 times higher than what they value a specialist physician or surgeon with 14 years of experience, is that they also don't tier their consultations, meaning that the longer you spend with a patient, the less they're paying you. because a medical aid, whether you spend 15 minutes, half an hour, or 45 minutes with them as a surgeon, they pay you a fixed rate. That's what they call their 100% base rate, which in effect is actually 300% lower than what it should be. This was analyzed and put together in a private practice cost analysis by Healthman, which is a governing body for private practice medicine, where they say we should be reimbursed at about 37 Rand 90 per minute, which is 300% of what the medical aid is currently paying. So now you are spending time with a patient who has a complex case, and you spend 45 minutes with that patient, but they're reimbursing you at their baseline rate. So as you go up from 15 minutes to half an hour to 1 hour, they are basically paying you less and less and less per minute of your time spent with a patient. So there is no, irrespective of time or complexity, the medical aids reimburse the same fee. So that's what one needs to understand. And when it comes to surgery as well, for instance, and private practice costs, you've got some private practices which are really capital heavy, like ophthalmology, like radiology. We're looking at the rates at which medical aids reimburse you. If you take off tax and VAT, you're barely going to be able to cover your costs if you're working at about 80,000 minutes per year.
Sure.
Which sounds a lot, but when you actually take the cost of service into account and what the medical aids reimburse you, it actually comes out to what a newly qualified house doctor earns in the province. And one's got to remember that those doctors don't pay VAT. So we are paying VAT, we're paying tax, we're paying our overheads. The reimbursement models have not been changed in the last 40 years.
Wow.
So when a patient comes to you and says, oh, no, but you're charging 200%, 300%, what one needs to actually realize is that is actually the fair and ethical rate, not the 100% baseline rate that medical aids are prepared to pay. It's basically manipulation of words. 100% is automatically resonates with a patient and saying, oh, they're going to cover everything. 100% means everything. But when you look in the fine print and you understand your scheme of benefits and the plan you've chosen, it's actually quite the opposite.
That's very interesting. Dr. Joseph, getting back to your field, is there a co-payment due on different lens technologies?
Yeah, so specifically the field I work in is refractive surgery and refractive cataract, refractive lens surgery. Medical aids cover up to a certain amount, irrespective of what lens technology you're using. And 90% of the patients I see come to me because they're looking for solutions to be more spectacle independent or contact lens independent or reading glasses independent. And those lens technologies automatically come at a higher price. So we get sold those lenses by the companies at X price, but the most of the time the medical aids are only prepared to reimburse at X minus 200%. So a significant portion less. But it's important that as the physician, that when we sit and counsel our patients and consent and actually get the quotes put together, and our Mariska does that, she will put these quotes together and say, listen, your medical aid will not cover the full amount on this lens, but it is your responsibility as the patient, because remember I said, where does the contract lie? The contract lies between the patient and the medical aid, not between the medical aid and the doctor. It's got nothing to do with the doctor at the end of the day, especially if you're not contracted to medical aids. But they need to, as the patient, then find out from their medical aid what and they're going to reimburse, how much they're going to pay for the surgery, how much they're going to pay for the lens, so that the patient is informed and says, okay, well, I know I'm in for exactly X amount after the surgery.
So, Dr. Joseph, what if I have a gap cover and there's a co-payment?
Yeah, very good question. I think the gaps are seen nowadays as probably more beneficial than the medical aids themselves, because the premium you pay for your gap cover is comparatively small when looking at the premium you pay for your medical aid. And gaps are designed to bridge the gap between what your medical aid pays and what the surgeon's fee is. So most of the surgical or the consultation portions may be reimbursed by your gap. Once again, the patient would have to find out what their contract is with their gap cover and what services they'd cover. But most gap covers don't pay prosthetics or lenses, the co-payment on those. And those are usually then the liability of the patient. So it's important to understand that your gap's going to cover X, your shortfall is going to be Y, and you're happy with that. I think some practices are happy to deal with gaps, but it just means employing more staff for a service that is actually a contract between the patient and the medical aid. So we don't deal with gap covers. We'll happily give you your invoice and what your balance is. That gets settled with the practice, and then you send that invoice to the gap, and the gap can reimburse you directly. That's actually a really, really, it diverts me to another interesting point, is that if a doctor decides not to contract with a medical aid, and there's one or two of the big medical aids in this country that do this, the medical aid pays the patient for the surgical procedures, pays the patient for the consultation procedures, and not the doctor. And that can, in certain instances, become a problem. Most people are ethical and will understand that that's not their money and that needs to be transferred over to the doctor. But in some instances, that money can be kept by the patient when it's paid out to the medical aid. Wow. The medical aid, so then, is holding a gun to the doctor's head to say, well, you know what, if you don't sign a contract with us, we'll pay the patient, which is illegal. They can't do that, and it's a bit of a catch-22, and it's one of the reasons why most doctors end up signing agreements with medical aids. They don't want to be hassled with payments, and they don't want to be chasing patients for co-payments, and it just makes their life easier. But if you understand that to try and run a practice at a medical aid rate, especially in the capital-heavy practices, there's only two ways in which you're going to survive, and that is either over-servicing, so it's saying to patient X, listen, I think we need to see this little lesion at the back of the eye again, or this lesion on your foot doesn't look so great. Come back in 2 or 3 weeks' time again, and we'll run these scans. They send it off to the medical aid rate, at a medical aid rate to the medical aid. They get reimbursed at the medical aid rate. So they make up, in inverted commas, the private fee. And the second way is to run a high volume practice at a contracted fee, which is interesting. During the COVID pandemic recently, that was all reversed. So people suddenly weren't getting sick, and they were staying away from the doctors. So a lot of practices that were reliant on a medical aid rate reimbursement suddenly started taking a lot of strain, and then realized that this reimbursement rate was insufficient to survive. So it's my advice would be is, if as far as you can, depending on your area as well. It's very difficult to say that, sitting in an area where you see a certain a patient base and who are driven towards refractive surgery, which is mostly a cash paying procedure anyway. But certain areas, those patients are dependent on being seen at their medical aid rate. So it does make it difficult. I'm certainly not saying one is right, one is wrong. You've got to do, at the end of the day, what's right for your practice and your area.
Dr. Joseph, when a medical aid contracts a DSP, how do you know that the DSP is actually good?
Well, you don't. And that's the thing. The medical aids don't put any emphasis on that. It's just the doctor decides to contract with the medical aid. And I think in an ideal world, that medical aid should say, right, you want us to pay you your fee for service, which should be at about 300% of medical aid rates. We're going to vet you. Let's have a look at all your results over the last 2 or 3 years, your clinical results. And most doctors who are really keen on outcomes will have a database of their outcomes. So you're watching them constantly. You're making sure your outcomes are as tight as can be and as excellent as can be. And then that's going to be basically down the road saving the patient and the medical aid money. But medical aids, unfortunately, do not put any emphasis on outcomes-based measurements. It's medicine. It's just the fact that, is this doctor prepared to contract at my fee so that I can save, irrespective of the outcomes? Yes, no. Then they make the decision based on that. So it is a sad reality that needs to change. And I think that's where, slowly some units are showing medical aids that, listen, yes, pay us a global fee, but these are the surgical units you need to look at in terms of outcomes. And these are the standardized outcomes. And if everyone is obtaining these outcomes, then it's good for the patient, it's going to be good for the doctor, and it's going to be good for the medical aid.
And Dr. Joseph, one more question. When a doctor charges a private fee, is that doctor overcharging, or are the medical aids not paying you your due fee for the service?
Yeah, so I think the hit-home point here is that 100% of what medical aids pay, or their baseline rate, is unethically and illegally low rate, as I explained in the beginning of the chat. It hasn't changed in the last 40 years. It hasn't changed with inflation. It hasn't changed with practice costs. And when you look at the cost model that HealthMan had put together, that should be at 200 to 300%, or close to the 300% mark. So, no, a doctor is not overcharging when their private fee is 300% of the medical aid rate. It is, in fact, a case that the medical aid is under reimbursing the doctor. But then again, the patient also has the option to choose certain plans. Some plans will pay 100%, other plans will pay 200%, and if you're on executive plans, for instance, they'll pay 300% of the medical aid rate. So it's important as a physician to have my patients understand that it's not a fact that we're overcharging. We pride ourselves in quality care, quality service, quality outcomes. And if you look at the time spent to get to where you've gotten, and the reimbursement that medical aids are prepared to offer experienced clinicians and surgeons versus what they offer their principal officers, you're definitely 300% shy of where the mark should be.
Dr. Joseph, thank you so much. What an insightful conversation again today. How do we get in touch with you?
Jan, so we're based in Knysna at just adjacent the Advanced Health Clinic. You can chat to Mariska on 044-150-0085. Our website is www.drdillanjoseph.com. That's drdillanjoseph.com. And we've got a number of social media channels, including YouTube, where you can find a lot of our informative videos. We're on Facebook and on Instagram. Please look us up, give us a like, and if you've got any questions, feel free to get in touch.
Thank you so much. Until next time, Doc, enjoy the rest of your day.
Perfect. You too, Jan. Thanks a lot.